afternoon, and welcome to the fourth in our series, our pop-up ecosystem. My name's Andy Bleeden. I'm the director for our ecosystems and membership at the European Connected Health Alliance. You've joined what is now our fourth ecosystem, pop-up ecosystem. This will be targeting a theme which we've excitingly brought together on hope in COVID-19 time. You'll see we have an exciting array of speakers today. And we'll go through those and introduce you to those very, very shortly. Gregor, if I could have my slide up, please. Whilst we're waiting for that, we'll be hearing today from Richard Corbridge, Margaret Worski, Jon Georg Petrovaj, Lizashwell Payne, Bislin Brainy, and Mike Kinney. Okay. By way of introduction, as I said, this is targeting our hoping COVID-19 time. Next slide, please. Just a word about our pop-up ecosystems. What we're looking to do with these is to give people an opportunity to go online and find out the best practice and solutions and our demands from our regional ecosystems. Our ecosystems are there to, as what we said before, to break down in silos in health and social care, but also to transform it. Transform both healthcare and social care, and never has there been more need to do so than now during these current times. But as you can guess, for now, this is going to be in an online format. Next slide, please. Our pop-up ecosystems are accessible to all. They're not based on a geographical area, and they're leading with a need. Okay. Again, we still want to see patients at the heart of this. We can you have the next slide, please? We talk about bringing our ecosystems together. We now have more than 40 ecosystems across Europe, and the idea is to bring the best practice from our members and their members from each of those ecosystems to target the area of COVID-19. Next slide, please. Right, Gregor, can I just interrupt you? We've got some difficulties with our slides here. I've sent you some slides this morning. Can you replace these, please? And I'll continue with my presentation. We're just going to switch some slides. Won't be a second. That's the right ones. Lovely. Slight delay here. That's the right ones in front of you. Yes. Okay. Switch through to the third slide, please. Lovely. So what we've now done, we can put that in presentation mode. We've now built quite rapidly a dedicated web page for our pop-up ecosystems. And we also now have a series of themed and geographically focused events over the coming months. And we've also built what we think is a very rapid and exciting demand and supply offer. Next slide, please. You'll see, if you go to our website, a dedicated space on pop-up ecosystems. And this is a series we've decided to build rapidly, but also move to a more thematic approach. So if you go next slide, please. You'll see we've got a series now, which will be happening at the moment, as you can see, every fortnight, but we're also building in some more capacity. We've got our next one, following this one, will be targeting care and social care. We'll be following that up with one which has been very, very strongly requested by our ecosystems, that of mental health in COVID times, because of the enormous pressures on our health and social care systems that we're seeing in very many different areas. We're also looking to target the issue in the area of data donation, and how that's been rapidly changing just over the last couple of weeks and months. Next slide, please. But moving on from that, this week we're building now the program that will come in late June and through we think over the next coming months, because we're well aware of we're listening to people who are saying that we will be looking to be online for some considerable time. So you'll see we're planning events around the thematic area of dementia, matching demand and supply. Our Finnish network of ecosystems have got an event booked in now for May the 15th. We've got one targeted for the beginning of June with our new ecosystem in Canada, and we're welcoming them in a joint European-Canadian event. We also will be featuring more of our Latin American pop-up ecosystems. You would have seen, hopefully, last week we ran the first of a really exciting Latin American pop-up ecosystem, targeting Mexico, Uruguay, Argentina, Brazil, and Costa Rica. Next slide, please. And obviously we've built and delivered a member-to-member collaboration area, which we're sharing with our members and also on our website, with a large array of both demand, supply, and funding opportunities. The next slide, please. And today, we're really pleased to be bringing together what we think are key leads in the area. And we're targeting an area today, which is around hope. Hope in as much that COVID-19 has brought about some tremendous changes and rapid development, none more so in the deployment of what we see as existing digital health solutions. So this is where COVID-19 has brought about a massive change in the deployment of what we already know to be successful solutions, but on a mass scale and in a time scale we've never ever seen before. That's enough from me. I'm going to hand over now to Richard Corbridge. If we could switch some slides. Richard, I'm going to ask you if you could to turn your camera on and introduce yourself. And we'll come back to any questions at the end of this session. Okay, Richard, over to you. And Richard is not in the need of any slides. Richard,
okay.
Over
Brilliant.
to you.
Can everybody hear me okay and see? Just check with Andy, I guess, who can speak.
Yes.
Brilliant. Okay. So thanks ever so much, Andy. And I guess that hope in these times is something that everybody who's working from home, needing a haircut, wanting to work out how on earth we didn't pay teachers several million pounds more than what we currently do, is what we really, really need. We need a new way of thinking. There's a few things that spring to mind in Andy's introduction and in preparation for today. One is something that we at my organisation, which is Boots, have been looking at over the last short period of time, is how impactful decisions are now and the change that happens as we move towards that. This phrase that's become common parlance in many, many areas around decisions and things you do in the next 10 days will have an impact and deliver healthcare in the next 10 months. But that impact must be considered for the next 10 years. I think one of the parts of the sort of title for this, as we put these 10 minutes together, is that race to the new normal, that ability to survive now, revive our healthcare systems, our healthcare businesses, and then thrive in a post-COVID, post-lockdown world, is a big part of how we change and what we need to do. The experiences that Boots has brought to that and that we've been working on over the past short period of time have really made changes happen quicker than ever before. And those changes have largely been around how we work with healthcare, and that's certainly my area of expertise and the area that we'll talk about over the next few minutes. Something did strike me that is really interesting, though, around language and people's ability to listen. While we're in lockdown, you'll notice every morning you're woken up by a cacophony of birdsong, much, much louder than normal. A friend of mine put to me recently that birdsong is louder because the birds can hear themselves much better. That ability to have less noise in the background, that concentration on one thing, on how do we have healthcare of the future? How do we continue to work together, to collaborate, to make sense of the situation we're in, and truly begin to offer a different way of working, is something that's been a really big part of our approach. A new language, a new ability to listen, while it's quieter, while the focus of many, many organizations are so laser sharp on the delivery of healthcare in a very different way, is a big part of our direction where we're going. I think as we've looked at implementing virtual GP services, for example, so putting primary care within the Boots environment. Over 2019, we did that in store. We offered customers the ability to see a GP by coming into store, sitting in a consultation room and connecting to a GP virtually. And it was successful. As we moved through 2019 and into early 2020, we began to put the ability to put that together through bootsasllarge.com digital presence and went live with that just before lockdown was announced. During those initial stages of lockdown, we took away that capability to enable all focus to be just on the NHS, but we'll drive forward and put that back in place. But the key things that taught us is how quickly the systems can work together, how organizations like a retail organization, a community pharmacy organization like Boots can work with new organizations who are delivering platforms for healthcare businesses, virtual healthcare capability, whether that's our partner Livy from a primary care point of view or others. We're currently looking at physio, we're looking at dentistry for under 16s. We're looking at the ability to offer how much of the healthcare journey can be offered from a virtual platform. How can we offer the ability for you to stay at home and still receive health? The big fear that keeps me awake as an ex-NHS employee, as a 25 years in healthcare, is that bow wave of return to healthcare. We heard this morning in the UK that the predicted number of deaths in 2021 related to cancers that have not been treated or not been seen in the crisis is in excess of 18,000 people. How can we make sure that our virtual services, our ability to have hope, to strive for something different, is set up in a different way? Building new services during this time is very much around that new language, new culture, new connectivity, collaborative sense making together. And I know Liz will talk an awful lot about how different organizations can come together to truly deliver a customer journey that is focused on patients first, on clinicians first, is no longer focused on how do we make it work within the governance functions, but is now has an ability to persuade the right people that we need to strive to deliver virtual services. Healthcare must continue during this crisis. And if we're truly to revive and thrive as we move into the latter part of 2020, then we have to set ourselves up to continue to offer those services. And I guess that's a big part as well. How do we maintain the lessons that we've learned? How do we make sure that in the new world, as we step away from the crisis, as we move back to a business scenario, a high street for us in our case, a healthcare function that continues to deliver, that the lessons of the things we've changed for the positive remain? I think that's a really big part of where we go. How do we understand in an organization of my size, where we've got upwards of 50,000 people in the workforce, how do we understand every one of those 50,000 people's lessons they've learned and bring those in a really strong way to the fore of new delivery? I think the lessons that we've learned around delivering virtual GP, putting community pharmacists into NHS 111, and new services across the estate around a healthcare focus over the next few weeks are that our governance is right, but we need to be able to move in an agile way. McKinsey published a report overnight around running agile teams in remote scenarios, which is a fascinating read, and I urge all of you to have a look at that. Because running an agile team, working in Scrum fashion, working in ways where we test and learn with customers whilst we're in lockdown, whilst we have the COVID crisis we do, is difficult, but it's not impossible. And the hope around reviving our businesses, reviving our healthcare capability now has to be maintained as we move forward and begin to deliver in a different way. I on purpose didn't want to do slides today. I wanted to just give you those views of where we're going and hopefully take some questions as we move through the next hour or so. But where I think we will learn the most is that exponential change that we always knew was the case in healthcare, and how digital supports healthcare is never more so than now. That new normal that people don't know what it means yet. It's become common language to describe the new normal, and yet here we are unable to define what that is. But that exponential change to get there, the fact that we now have virtual primary care across the UK. In December of last year, we wouldn't have conceived that in 3 months we would have cracked the problem that has been a 10, 15-year problem. We talk about new technology, but let's face it, what we're offering today to offer a GP appointment over a virtual connection is not new technology. Video conferencing, the ability to see me, to hear me, to interact with me, has been here for a decade plus. And here we are seeing that as innovative, as a change in the way we deliver. So hopefully that sets the scene for some of the other speakers and sets the scene for some of the questions. I think at that point, I hand back to Andy.
Thank you for that, Richard. Very interesting and very relevant. I think many people have asked the question, and I've got some questions in already, on will will people go back to the old ways, or will they embrace the new way? Do you think at the end of this crisis? Because I think perhaps we'll do a Q&A later. But very, very interesting because there's lots of possibilities for things to change. Okay, I'm going to move on. We'll come back to questions and answers hopefully towards the end. I'm going to introduce now, very, very pleased to welcome back Margaret Risky from the Scottish Government, who's a digital health and care lead there. And she's going to talk about, Margaret, you'll need to turn your camera on, by the way. She's going to talk about technology-enabled care, a story of scale-up from Scotland. Over to you, Margaret.
Okay, good afternoon, everybody. Can you hear me okay?
Yes, we can.
Good. Okay, now delighted to be part of this pop-up, and I think it's providing a great opportunity to connect in with colleagues, hear about some of the changes and I suppose learning that's going on. And I think I would echo a lot of what Richard has said about how we can maximize, I guess, the opportunities this challenge has brought to look at some sustainable solutions. So my name is Margaret Horisky, and I'm responsible for the National Technology Enabled Care Programme in Scotland. And I'm really going to just talk a little bit about what's been happening over the last few weeks in terms of rapid scale up, and using an example of our Near Me Attend Anywhere video scale up as something to draw out, I think, why we've been able to do what we've done. Next slide. So in reflecting really on our ability to do a rapid scale up, and I'm talking about doing something in weeks rather than the plan would have been a number of years, I was reflecting on what some of the conditions were that supported that. So on the policy side, we've had a clear policy around technology enabled care since 2015. We published our digital health and care strategy just under 2 years ago, and that again reinforced the importance and the role and contribution of a range of technologies, including VC, to support access. We have our realistic medicine, which is very much about personalising care and health, and that also talked about the role digital can play in terms of facilitating greater control and choice for citizens. And also the work we are doing was set out in our Scottish budget. So quite a strong policy context, and that was supported by a strong programme. So building on some earlier work that was done around video consulting, the tech programme provided funding for early adopters and some of the national work required. We procured the Attend Anywhere platform in 2018, and that's been what we've been using. And I know other colleagues in England and Wales have also been using Attend Anywhere. And in 2019, we provided some funding to all our health boards in Scotland. So we've got 14 territorial health boards, and also some support and change management to support implementation of Near Me. And again, back that up by undertaking an evaluation, which was progressed by Trish Greenhow from Oxford University and is just due to report. Next slide, please. So business as usual in normal circumstances. This was a chart that we set out in a paper that I took to our tech board in February, so not that long ago. We had approximately over 1,000 consultations a month using our Attend Anywhere platform. And by March 2021, we were aiming for shifting that to 3,000 a month. That was still seen as being reasonably ambitious, although still a very small percentage of all consultations. But we were taking an incremental improvement approach to this, looking at how we'd extend into primary care and also social care, as well as some of the outpatient and hospital work that was done. And from our experience, we saw that from initial tests of change through to development phase, preparing for scale up, at scale adoption and business as usual, we were looking for about 3 years. And the example here was given as Highland, who'd been working on this for a number of years, and they saw that they were moving into that at scale adoption, but that was after 3 years of work. Next slide, please. So why Near Me now? So we're using Near Me as the name of our program. As I say, it's supported by the Attend Anywhere platform. So sometimes Attend Anywhere is used as well. So why was Near Me seen as being a particular opportunity as part of the response to COVID? Well, firstly, to reduce exposure for patients and other patients in practice as well as clinicians, to undertake consultations for people experiencing COVID symptoms, for continuity of normal and priority services, to enable home working, and that's also been supporting clinicians who've had to self-isolate. They've been able to continue some of their work, to provide some decision support and to provide resilience. We've also been doing work recently with care homes, and again, that's been receiving a lot of attention in Scotland as well as elsewhere in the UK around some of the significant challenges we have with our very vulnerable population in care homes. And we've also been doing work with our prisons as well as our health services. Next slide, please. So you can see that this graph is showing a significant increase in consultations. So remember back, I was saying we had about 1,000 consultations a month happening in February, and we were aiming for 3,000 a month by March 2021. You can see that last week we had in excess of 9,000 consultations in 1 week. So, you know, we've seen huge growth. We've also seen a big growth, particularly in primary care consultations. We have rolled out guidance across primary care and secondary care services. We have been working with colleagues in our improvement organisations to support the local practice on the ground. We've been working to ensure that primary care and other services are equipped with the technology required, which is not overly sophisticated, but they need to have a good internet connectivity and they need to have a webcam. You can use your own device as well. So I think we've been trying to encourage people not to see the actual equipment as a barrier, but actually clinicians can use their own device if there isn't an appropriate device available. Next slide, please. So what made the difference in terms of moving from that sort of slower, more normal, I suppose, way of incremental scale up that, as I say, was going to take us a number of years probably to get the coverage we're getting right now. So I think, as Richard has articulated, digital interventions are now seen as of critical importance by all. And we were given a very clear mandate from our health minister right through to our policymakers and senior officials to extend the Near Me approach to all primary care services and secondary care in a matter of weeks, not years. Within secondary care, we've identified 7 or 8 key priority specialties, but we're also recognising as we move through the emergency phase into the recovery phase, we have to also be able to look at how we respond to the unmet demand. I mean, a lot of elective work, if not most elective work, has been cancelled in Scotland, and it's how do we begin to address some of those needs as we move out of the emergency phase. We were able to undertake a speedy procurement, and we were able to use emergency procurement to do that, to extend our platform significantly, to be able to cope with the additional demand, and also, as I say, getting our GP practices and other clinics equipped. I think our ability to scale up was based on a lot of the work that had gone on in the previous few years, where we'd addressed a lot of the barriers at national level and also been working with all our local boards, even though it was small scale, but there was local capability within local boards in terms of being able to take forward this work. As I say, training, practical support and evaluation. I mean, all of these, I think, have helped create the conditions for a rapid scale up. We've seen redirects of staffing resources from wider primary care and secondary care improvement programmes. Something like 50 staff were redirected from routine primary care improvement work to support the Near Me scale up. So that wouldn't have happened in normal circumstances. And there will be something we have to address about how we sustain support going forward. We've done quite a bit of work as well on our comms and communications. There's been some public awareness done with the local public, as well as working with our various professional groups. And there's a real accountability for delivery. So this is not in the nice to do box anymore. This has actually been seen as something that's really required to be delivered. There are still some issues that we're working with. So, while GP practices have basic equipment, it's not in every GP's room. If a GP starts with a telephone consultation and wants to move quite swiftly into a near me consultation, there needs to be a log on for that. So we're trying to look at how we can streamline that process so it makes it easier for the GP or clinician to do that. We're still working on that clinical leadership and engagement across the specialties. We've a lot of interest from our non-health colleagues as well. As I say, we're working with care homes to try and improve access also. So we've a lot achieved in a few weeks. I think the real opportunity is how do we sustain some of this or a lot of this as we move into that recovery and renewal phase that Richard has talked about. So that's a very quick example of some work underway in Scotland.
Thank you for that, Margaret. That was fascinating. There's a phrase in English that we use, which is this is exactly what it says on the tin. Before you go, I think we wanted to have a really good example of existing technology, and that's nailed it in one. So thanks for that. I'm conscious you've got to leave before we do the Q&A session at the end. What I would like, we've got a question in, and I'm going to push all the questions towards the end. It's from Brian O'Connor, asking this is a really good example of practical deployment. Do you think this will be the new normal?
Yeah, I mean, I think it will be the new normal, and it's interesting. I've had a few sort of anecdotal examples of, in interactions, nothing to do with work. I mean, one was on an online Pilates lesson, and there was somebody talking about their work, what they were doing, and they said, "Oh, we're using this near me technology, which is great because we're able to work and with our patients, and the patients really like it." So I think people are beginning to really engage with it. It's not suitable for everything, and I think we need to be clear around, the range of approaches that need to be adopted. But I think we will see this as becoming much more integrated in the way people deliver services and the way I think citizens expect to now access healthcare interventions and support. As I say, I think there's still a bit of a challenge to how we keep the momentum and the focus and the sustainability as we go forward. We need to be able to address any barriers that come up, be those technical or be those sort of process or change management barriers. We need to keep that clinical leadership and engagement, and we need to keep the public engaged in a constructive way around the opportunities that this provides. So as I say, I think we've a lot learned, and I think a lot more to do.
And it'd be interesting to see how much demand there is from patient groups and citizens, because I for one recognise that, would I want to go back to the old ways as a consumer of health and social care? I'm going to take advantage. We've got a couple of questions coming in, and I'm not going to do this for us, but just obviously with Margaret coming to leave, do you allow? This is a question from Laurie Hawkins from Australia. Hello, Laurie. Do you allow different services such as dietitians and pharmacy, etc.? And do you have a national director of services on telehealth?
Yeah, I mean, there's a whole range of services that have begun, that had already engaged with our Attend Anywhere Near Me, and obviously Attend Anywhere has come from Australia. So there are a range of allied health professional services that are also engaged with it, pharmacy examples as well. As I say, there's increasing interest from non-health services as well. We've done some really interesting work with rape crisis centres, working with people who are not digitally connected. So I think that's one of the issues, that in Scotland we still have people who don't have a device, or even if they do have a device, they're not able to access internet on a regular basis, or don't have data on their phone. So we are looking to see how this can be seen as not a charged for service. So I think there's there's an interesting program in Scotland that's been called No One Left Behind, and it's really trying to address this issue of digital exclusion.
Yeah.
Because it's fine having services like Near Me, but if we're going to further disadvantage some hard to reach groups, we need to be able to address that. So I think it's been used in a whole range of areas, and obviously our focus is more now in the emergency, but it's around how we extend that going forward.
And I'm assuming, just thanks for that. I've also seen we've got a question from Adam Giangreco here. Would you have data to say, well, these are the numbers we're getting now? Obviously, you've got those for how many people are using Near Me, but then compare that with numbers who would be seen in face-to-face consultations as well. I'm not asking for the figure, but do you have that sort of level of data?
Yeah, we certainly have good secondary care data in terms of all the numbers of people that are seen in various outpatient clinics, and we have the Near Me data now, which is beginning to track clinics, hospitals, GP practices. We probably don't have as good information around the primary care and community services in that way, and I think we're not currently collecting nationally the number of sort of telephone calls, for example, GPs are making, although we know that, the vast majority of interactions at primary care are now starting with the phone call, and people are only being seen face to face if that's considered required. So we have reasonable data, but I think there's more granularity that we probably can develop in terms of this going forward.
Interesting, and thanks for that, and thanks for the questions as well. I'm going to move on, but before I do, Richard, I don't know if you could just switch your microphone on, if that's possible. I'm conscious you've got to get off as well. It's almost the same question really to yourself. Is do you think that the authorities will just, at the end of this say, sorry, chum, we're going back to the old ways? Or do you think this is it for do you think they'll embrace this new way?
I don't think they can, because I think the system will require the stuff that we're putting in place now for the next longer period of time than just the current crisis. I think return to normal rather than defining new normal is going to be a lot more complex and difficult and challenging than any of us really understand or believe today. And therefore, I think it won't be possible to say, let's just revert to how we used to, because we're going to be looking at new ways of delivering healthcare that are the only ways of delivering healthcare in the new world. And I think when you look at that, the way healthcare systems haven't done normal healthcare during the crisis, the bow wave of picking that gap up once we start to return will be so big that things like virtual healthcare and other solutions that have been put forward, even down to a new focus and concentration on wellness, will be something that we just cannot move away from.
No, I think it's this. Somebody remarked the other day, this is a bit like after one of the previous wars, where empires that were there previously have been shaken so badly they cannot go back to the old ways. Anyway, thanks for that, Richard. I'm conscious of time. I want to get moving. This is one of the beauties of this format, is we're going to now get on a plane really quickly, bypassing the check-in lounge, and we're going to go straight to Romania, to Cluj-Napoca, where I'm really pleased to introduce Ion Petrovi from our Transylvanian ecosystem, from Fresh Blood. Ion, the floor is yours, please. Over to you. We can't hear you, Ion.
Nope. One moment, please.
I can hear you now.
Okay, it's okay?
Yeah.
So hello everybody. It's a little bit, how to say, difficult for me to speak after my previous speakers, which are sharing how the things are being taken care of from an administrative point of view, being the fact that even though we are part of the ESH Alliance ecosystem, we are coming from the ecosystem more than we come from the how to say, administrative part, or with the big power. So I will start. First of all, everybody knows where Scotland and UK is. Most of you have heard about Transylvania, but we are happy that Hollywood is providing every year a new reason to remember it. this is the region. It's northwest of Romania. We have several names: Transylvania, Erdely, and Siebenbürgen. It depends on the language. We are quite visible at the national level, and we are aiming to become more visible at the international level. Fresh Blood is a catalyst organization helping the people and the projects and to grow, and also trying to forge partnerships at the level, at the local, either private and public level, or also through international collaboration. Hence, we are also part of European of ECH Alliance. We are connected with the tech ecosystem, we are connected with the healthcare system, and at the European level, we are very well connected with European EIT Health, which is one of the few European organizations which are taking a closer look to the Eastern Europe and to Romania in particular. And our priority has been since forever to strengthen the community, to foster healthcare innovation projects, and to build partnerships. And now we get to the current point. I mean, the topic of the webinar is the hope. And the hope has to start, me myself being a doctor and project manager for Fresh Blood, with a proper understanding. So the start of the story is February 2020. Telemedicine in Romania is actually unregulated, hidden under remote advice, and practiced in psychotherapy. And there actually are a number of psychotherapists from Romania which are delivering the consultations all over the world, in the Romanian communities, but also outside of Romanian communities. I would like to remind you that we have an estimate of 4 million Romanian nationals residing either in Italy, Spain, France, and UK, just to give you an example. Then we have the COVID-19 impact. March 16, 2020, we have the emergency state in Romania declared by the president, and they begin to shut down movement of people, and they begin to prioritize resources. And what happened March 24, they decided that in the hospitals, including the private ones, you can only put emergencies in order to take care of them, and people over 65 can only leave the house from 11 to 13. Hence, they cannot go to the doctor. You all know that these kind of people are among the most in need in terms of medical services. The immediate consequence, medical activity decreased less than 80% in communicated and confirmed both at the private sector level and also at public sector level. Then we have the push, and in March 30, 2020, the government and the National Insurance House together accepted remote consultation, and only remote consultation, self-reported by the doctor through any communication technology. So there was no specification. I would like to remind you that currently there is no framework for telemedicine, technical, in terms of reimbursement of anything. They said if the doctor is reporting it, they can report it after all to get reimbursed by the insurance house. And I would like to pinpoint you this chart, which I find extremely relevant. We are very close to the technology part, and we have always seen technology as an opportunity. And I like this chart coming from a consulting company, which says that first of all, first mover in the new field, like in innovation, is the technology. Basically, we had the telemedicine as technology for tens of years already. Then you have the individuals, of course, as long as technology was only available for a couple of high-tech guys or to a couple of high-tech enterprises, this was limited. But now every individual has in his pocket something which can have a camera, something that has some sensors, and suddenly individuals begin to understand their powers and not only use it, but also demand it to be used by somebody that's providing services for them. It's very common knowledge that doctors have their WhatsApp full with messages from patients, with questions, with advices, or even groups where they discuss things. Then you have the businesses, because they will see that technology and individuals become how to say, familiarized, and there is maybe an opportunity. And then the last, usually, it's the public policy. And we have seen some examples of public policy actually embracing this, being prepared and being able to maybe split some priorities. And unfortunately, our public policy is still catching up on that. So what we have now, and that's the topic of our presentation, we have a compression of all these four things. So you have technology and individuals and businesses and public policies moving almost in terms of days. And this is solving, because now we have to solve a problem. People, patients and doctors don't want to risk things that they can control through technology. So the next immediate outcomes, I'm talking April here. The major private healthcare providers have established their own telemedicine services in a week. Basically, they extended their IT services. They something, I would say, bricolage. It's in French. I don't know if the word is in English. It's just something handmade. It works. It's not regulated, but it can allow them to service the patients. The smaller healthcare providers begins to use some smaller solutions. There have been, as I said, some solutions used in other fields, and now they are coming to use in telemedicine. Individual doctors are actually using WhatsApp and FaceTime and phone, because phone is a technology. What we did as a community and as a Catalyst organization, after being fed up with the calls and the messages about this telemedicine, what can be done, we started the Telemedicine Romania and Telemedicine EU Facebook group. On Telemedicine Romania, we have 1,900 members plus, and we organized 4 online events through Zoom and Facebook, and we had an audience of over 30,000 people, with people that are actually doing telemedicine, with people that are actually using telemedicine. We had invites from France, a doctor that has built her own telemedicine platform. We have another supplier that proposed this in order to get the people along. What would be next? We do not know exactly. Currently, the emergency state in Romania will last until May 15. The latest data, we have seen some increases in numbers of consultations presented before. What we know now that private healthcare sector, 50% of their activities through telemedicine, and the individual doctor consultation is 80% through telemedicine. The public health sector, due to the fact they didn't have the financial incentives, actually one of the laws said the publicly owned hospital will get a lump sum in terms to be funded, and it's not going to matter how much work they do, which means that they have less incentive to move in this field. So it's moving to their level, but a slower usage, and mostly driven by doctors that have also public activity in the private sector. What we did as Fresh Blood, we initiated the coalition to make the telemedicine regulated. It's going to be a tough cookie. And also during last week, we coordinated Romanian EU versus virus hackathon participation. More than 1,400 people participated from Romania. And we are preparing the follow-up for the teams after the hackathon. In that hackathon about the challenge on telemedicine, I coordinated it, and it was something like 200 ideas. Many of them were from Romania, and we believe that these teams need a follow-up to become maybe part of the local ecosystem. We are constantly aiming for the partnerships. If you want, reach out. We are focused on Eastern Europe, Southern Europe, but open all over Europe through ECH Alliance, as is seen there. And if you want to join us on healthinnovators.eu. It's a Facebook group which is in English. We are communicating this actively. It's also available on LinkedIn, and we'll be happy to see whether there are opportunities to collaborate. Looking forward to have a better structured local ecosystem in Romania and to forge partnerships with the members of ECH Alliance. Thank you very much. Hello.
Thanks for that. I can fully endorse that message, and I can say quite warmly that our ecosystem in Transylvania just gets on with stuff, and I think there is a really good example of a different country's approach where people have turned around and said, this is the technology, we're going to use it, get over it. We're going to leave some questions for Jon for later on. I encourage you to make connections with him as well. We're going to quickly move on now because we're escaping out of Romania. I'm heading straight back to the UK. to welcome in Liz Ashall-Payne from Orca, who's going to talk about their brand new deployment of their COVID-19 app store. Over to you, Liz.
Thanks,
Cameras
Andy. Can you see my screen okay?
on, yeah, just stick full screen on.
Fabulous. Okay, so thank you so much, and thank you for inviting me to join this session today. It's been really interesting hearing what the other panelists have to say. So just to give you a little bit of introduction, my name's Liz Ashall-Payne, and I'm the founding chief exec at Orca. Excuse me. For those of you who don't know Orca, Orca is an organisation which is based in the UK, and our mission is to distribute high quality digital health solutions to populations, patients and healthcare systems so that they can really get the benefit of high quality solutions. If you do know us, you may know us because we review and approve digital health products on behalf of government bodies like the NHS, but also ministries of health across Europe and the Middle East. But actually our mission has always been to deploy these solutions so that people can get the benefit from them. And obviously, with the COVID crisis, what we've seen is this absolute requirement for digital, whilst we're all self-isolating or in quarantine, and particularly for those vulnerable communities who may be living with long-term conditions, or who may have had cancer recently, or living with cancer, or who are pregnant. You know, we need to support them to be able to self-manage in a way that we haven't had to do before. So what I'm going to talk to you about now over the next 10 minutes is really my aim is to help you know how to find the best digital health solutions to support your vulnerable communities and share with you the work that we're doing. I'm going to just quickly share with you a few tips on how to know whether a digital health or an app solution is safe, because obviously if we're going to deploy solutions, we must know whether they're safe. I'm going to share with you a couple of solutions that have met the review criteria that we take products through. And I'm also going to share with you a newly launched solution which you can use for yourself, for your families, or for your patients to be able to search for, find and deploy or recommend to your patients and communities. So the first thing just to say, this is obviously a current situation, but one that's really coming to life since the COVID crisis hit us, is we currently have access to almost 370,000 digital health solutions. In fact, it's probably more like 400,000. Every day we were seeing pre-COVID about 5 million people downloading one of these solutions. But what we weren't seeing was a true embedding of these solutions into clinical care or clinical pathways and into our healthcare systems. And there were 4 big reasons why we didn't see that. The first was awareness. People didn't know these solutions existed. The second was they didn't know where to find them because the app stores don't work. The third challenge, which is still the biggest challenge, is trust. Which products can you trust? And you know, since COVID, we've seen quite a lot of press about, is the data security of this product or that product good enough? So trust is still a really big barrier. And then the fourth big challenge is ongoing governance. And how do we know whether a product is going to stay the same post deployment of that product to a patient or to a population? And it's those 4 problems that Orca are particularly interested in. And these are the challenges that still exist today, but we're seeing a more engaged population. So we're now finding that more people want to find these solutions. But because that trust is at the core of everything, when we're deploying digital health solutions, either in a COVID crisis or other, we need to know which products are safe. And so Orca review and rate more digital health solutions than anybody else in the world. And we've been doing that for years. So we have this body of information about digital health solutions that we're able to utilise. But what I wanted to do is just very quickly give you a few top tips, because if you're going to be downloading an app or a digital health solution, just look at some of these top things when you download them. So the first is look at when the product was last updated. Unfortunately, 2/3 of all products on the marketplace haven't been updated in the last 18 months, which basically means that they're redundant, they're not being maintained and updated, and they will be glitchy, and therefore data security will be compromised. The second is really look at who the app or the digital health solution is trying to target. Is it trying to target clinicians, adults, teenagers, or children? And that's really important, because when we're looking at products, you need to work out what the risk is within that product. So obviously a product that's trying to support clinicians to help them do their job more effectively or more efficiently is much riskier than a product that's maybe around mindfulness and that's going to play music for adults. So really understand who the app's trying to target, and then that point 3, how complex it is. So if it is a product that's doing something pretty low risk, like playing music for mindfulness, that's pretty low risk. But obviously if a product's built on clinical algorithms, then that introduces quite a complexity and therefore risk. And make sure you understand what the functions and features are. If a product is going to link to social networks, for example, you might want to make sure that any risks associated with that are managed. If a product's going to provide personalised advice, again, you might want to make sure that those risks are managed. And this is the process that we go through when we first pick up a digital health product. What we then do is we then apply regulatory requirements to the products, and the regulatory puzzle is complex, so I've massively oversimplified it here into 4 jigsaw puzzle pieces. But really what you need to consider when you're looking at a product is the privacy, the data privacy, well managed? Is it data secure? And obviously, depending on what the product's doing with the data, what data it's collecting, how it's sharing that data, depends on the level of interrogation you might want to put a product through. Is it clinically safe? And this is the biggest area of interest for most people, and it's the biggest area from a regulatory and standards and best practice perspective. So what is the clinical evidence that sits behind the product? Is it a CE certified medical device? What are the clinical safety issues? And then finally, from a user experience, does it meet user experience requirements, which are particularly relevant to accessibility requirements? Now, you might also want to look at other areas, so not just the regulatory requirements. You might also want to do a bit of due diligence on the developer, who it's designed for, what it works with. This is really more important now than ever. We each have our own technical ecosystem. So for example, I have an iPhone, I wear a Garmin, and I have an Amazon Alexa. And so I will want any solutions that I use to work within my own personal ecosystem. And so that's really powerful when you're thinking about these products. And also checking in on the commercial models. You know, we've talked about sustainability, and we will have to pick up that conversation at some point about how do we make this sustainable for the future. Now, what we've done here at Orca is we've reviewed thousands of products against that criteria, and put that information into a global offering, which is covid19.orca.co.uk, which is basically a digital health library. It allows you to search, and you can go here for free. This is our support, I suppose, for the crisis. We're not able to go into hospitals and put ventilators on people or provide PPE, but what we can do is provide a resource of high quality solutions that you can now go and find and download in a safe environment, because unfortunately only 15% of all digital health solutions meet the quality that you would expect. So you can go to this resource right now, and when you enter, you can see that there's a search bar. So all you need to do is just click into that keyword search and start typing in any words that you might be interested in. The areas that we've focused on for this digital health library are the areas that you can see on the screen. So this is about supporting specifically the vulnerable communities that are at home living with long-term conditions, who are worried about managing their health, And the idea here is that if we can support them to stay healthy and well, then they won't need to knock on healthcare providers' doors, which means more resource can be directed to COVID. As you can see, there's areas like diabetes, respiratory, which includes things like asthma and COPD. There's also areas of well-being, though, around diet and fitness. And there are other things such as COVID-specific products. So we're seeing quite a lot of symptom trackers being launched, etc. So we're putting those products onto this app library. So you can search and find products that you might be interested in. Now, the apps that we've selected to go onto this environment, and by the way, when I say apps, I don't mean just apps on the App Store, I also mean digital health solutions, so web-based solutions, etc., has come from the already established 1,000 products that have already met a high level of assurity against standards. And we've chosen the products which have met the domain areas that I've just mentioned. Some of those products provide a replacement to normally receive face-to-face care, or that can support the general population to stay healthy and well, both physically and mentally. So if you want to go there, literally just go to the site, start typing in a keyword, and you can also use a filter system, which allows you to not only find the long list of, say, for example, the best anxiety apps, but also to filter according to your personal preferences and needs. And this is really important. So, for example, everybody in our house, I live with my 2 children and my husband, is probably feeling a little bit anxious at the moment because of the situation we're in. I think that's probably pretty normal. But if I'm trying to find a solution for my 6-year-old versus my 14-year-old versus me, what I'm probably going to find or need is something different. And so these filters allow you to filter according to personal preferences and needs so that I can find the right anxiety product for me or my children. There are other filters on there around cost, country of origin, and the functions and features that the product has within it. Now, once you find the right product for yourself, you'll then want some more information. And what you'll see when you go onto this site is quite a lot of information about the review process and how it can support the COVID situation. So the product that you can see here is one for post-knee surgery and injury recovery. So this is for people who may have had surgery prior to COVID, but that are going through some rehabilitation. And what you'll see is this purple bar, which lists the benefits of this product during the COVID crisis, how to implement the product, any relevant case studies or links to clinical evidence, and any changes to pricing, because what we're seeing is a huge swell of people offering support during this crisis. And so a lot of products are currently offering discounts or free of charge opportunity. And then you simply hit download and it'll either take you to the relevant app store, or if you're on a laptop, a QR code that you can scan. Now, one of the things I just wanted to make a note of, just to really go into detail a little bit more about that example that I gave about me searching for an anxiety product for us in our family. There are obviously other mental health areas, and I know that Andy's mentioned there's going to be a pop-up specifically on this. It's just fortuitous that I've ended up with this slide for today. But I really just wanted to highlight that depending on the situation, the product will be different. And one of the key things that this app library is being used for is for healthcare professionals to be able to embed high quality solutions into clinical care and pathways. So, for example, the first product that you can see is for primary care to use for low level stress and anxiety for an adult. The second is across the IAPT pathway, or the mental health pathway, incorporating cognitive behavioural therapies, and so on and so forth. And you can see that each of those products are different depending on the requirement and the need. So it was just really to push a little bit further to say this isn't about pushing just one product out for the population. This is about helping your population to be able to find the right product for them. Now, one of the critical things that's really important for healthcare professionals who are using this system is how do you manage any future risks or governance. So my background is as an NHS clinician, actually, and obviously if I'm going to recommend a solution to a patient, I need to make sure that it maintains its quality post that recommendation. And so what we've provided alongside this solution, or within the solution, is the ability for a healthcare professional to use it to not only download, but also to recommend an app. As a professional, I get a code, which I'll share with you in a second. Again, this is all free of charge. And a healthcare professional now gets the ability to hit a recommend the app button and to not just recommend to one person, but can equally recommend to a range of people the same product. So if I'm a clinician working with a group of patients who I know are experiencing anxiety and depression, and I want to recommend everybody this product, then I can put their details into the system and hit recommend. The patient then receives a text message or an email, depending as to whether you've sent it via mobile phone or across email, to say that you've had a recommendation. And to be able to get your pro account, it's very easy. You literally just go to the site, hit sign up, and then use Beat COVID-19, and you'll be able to generate your pro account. Now, one of the things I just wanted to share with you is that this solution has been launched about 3 weeks now, so just coming up to 3 weeks. And what we've seen is a huge growth in the number of people coming to this library to search for and find digital health solutions. So we've probably seen a 50% increase in numbers of people coming to an app library to search for and find trusted solutions. Just to give you a bit of an insight into some of the highest search terms, the highest search term is anxiety, followed quickly by asthma, and then diabetes, which is basically telling us that our vulnerable communities are actively searching for these solutions. I'm hoping that Andy can circulate these slides, because what I've done is I've also put in here a couple of useful resources around blogs, and thank you for listening. Please do join us.
Thank you for that, Liz. And yes, of course, we'll share your slides. Thanks for that really informative look through what is, I think, is a fantastic resource for individuals as well as health professionals. And thanks for sharing that with us. We'll be sharing these slides afterwards, and we also will be featuring more of Orca's content as well through our member-to-member emails that we're producing. Okay, back up to the Northwest, where I'm pleased to introduce Mike Kenny from the Innovation Agency, who run our very, very successful Northwest Coast ecosystem in the UK. Obviously does a lot of diving by the looks of it. But this is where people suddenly think, oh no, I should have changed my screen. Oh no, not my holiday photos with Granny. So over to you, Mike, and don't forget to unmute your mic. Can't hear you, I'm afraid, Mike. Need to press a button. There you go,
yeah.
You're on.
Yeah, I'm on. Great. Thank you very much, everyone. So first of all, can you see my slides?
I can, but you need to hit F5 and make them full screen. Lovely.
Yeah. I've done that. There we go. Right. Okay. Hello, everyone. Good afternoon, and it's my pleasure to talk to everybody today about what my organisation, the Innovation Agency, has been doing to support both businesses and also our NHS and health and care services in the Northwest Coast. So we look after NHS organisations in the northwest of England. So, and I'm the Associate Director at the Innovation Agency, which is the NHS Academic Health Science Network for the Northwest Coast of England. So I'm going to talk to you a little bit about who we are and what the Academic Health Science Networks do or did, and now we're in this COVID phase. And I'll talk through what we've been doing to support businesses, NHS health and care during the COVID crisis. And I've got some stories, some really interesting stories to tell about just how NHS and agencies and businesses have collaborated to develop solutions really quickly, and have been able to work through some of the traditional barriers in order to really speed up, the adoption of essential health and care materials to support frontline NHS and social care in this COVID crisis. And of course, we've got some learnings, and I'd like to share some learnings as well about what we've learned along the way and what we need to do differently going forward. And that's been a recurring theme through all of the presentations today around legacy and sustainability and so on. And I'll touch on that. So this is a busy slide, but if I can just summarise it very, very quickly, the Innovation Agency is one of 15 academic health science networks that cover the NHS in England. We're the North West Coast Academic Health Science Network. And what are we? Well, we're catalysts for innovation and transformation across health and care. Now, we're funded nationally to deliver work in our region. And we've got multiple funders actually who ask us to do work on their behalf. So NHS England and NHS Improvement commission us to do work around patient safety, and also programs around products and communities of practice for rapid uptake, which I'll talk about. We've got Office for Life Sciences, which are commissioning us to support businesses with market access to the NHS. And you'll notice that we also have funding from the European Union, and I think it was Ian mentioned the EIT Health. So we've got programs, European Regional Development programs, where we're doing business support for health and life sciences businesses across our region. And we're also heavily involved with EIT Health, even though technically we're outside of the EU now with the Bridgehead program and the Bridgehead Global program as well. So a little bit about who funds us and who asks us to do things. And in terms of what we do, if I could summarize, our role is around improving health, driving down the cost of care, and in stimulating economic growth, because if we help health and life sciences businesses to access the large NHS market, then they can grow, recruit people, and patients can benefit from the innovation products that they offer up and eventually are purchased by the NHS. And another busy slide, but I just want to explain a little bit more about what we do. So the NHS is a fantastic organisation that I am very proud to work for. But as we've heard, it takes a long time for the NHS to do things differently, to adopt new technologies and innovation. And actually, one eminent NHS person, Lord Aradazi, he often is heard to say that it takes 17 years for the NHS to take something that is new and available into full practice. 17 years for an innovation to become business as usual. So that's the role of the Innovation Agency and its sister organisations, is to shorten that time considerably, because we now live in a digital world and we can't wait 17 years for the technology to be adopted. So the NHS needs help in learning how to do things differently, and that's really what the Academic Health Science Networks, the Innovation Agency, do. And we support it in many different ways, communities of practice and individual products, through national programs and through funded programs that allow the NHS organisations to acquire technology, products, innovation, digital platforms at zero cost. And that's facilitated by the Academic Health Science Network. So some examples here. So we've got examples in cardiovascular disease, in gastrointestinal disease, in neurology, and in obs and gynae, and also in respiratory disease. So those are individual products that are supported, whose adoption is supported across the NHS by the Academic Health Science Networks. And then we've got national programs around communities of practice. And these are just some of those, in pain management, in atrial fibrillation, in ADHD, eating disorders, and there are others as well. And let me talk about the work that we do to support economic growth. So this is where we support businesses local to us in the northwest coast of England, and we've had a measurable impact on the economic growth in terms of creating jobs and securing investment for these organisations, as well as helping the NHS providers reduce costs and improve care. And in our last reporting period, we secured over £8 million worth of new investment for our businesses that we supported. They achieved £2.5 million worth of new contracts, and because of their access to the NHS market that we helped them with, they created 73 new jobs. So that summarises a little bit about what we do. But that was the day job. Until COVID-19, that was the day job. And now we've got lockdown. And I'm going to talk a little bit about Dr. Ian Hennesey here. He's a consultant paediatric surgeon and director of innovation at Alderhay Children's Hospital in Liverpool. When the coronavirus came along, we obviously, all of us, as we talked about today, had to adopt a new normal. And to quote Ian Hennesey, we achieved 5 years of digital transformation in 5 days at Alderhay Hospital. And that's something that Richard talked about, and Margaret as well, and Jan and Liz as well. You know, we've really shown what's possible. So let me tell you some stories about some of the achievements. So this slide is entitled, "Why weren't we doing this before?" So as we know, lockdown meant that we had to implement social distancing, and remote consultation therefore was an absolutely essential tool that we needed to adopt in order to continue to provide health and care, particularly in primary care and also in secondary care. Now, we've heard from Margaret already about their experience of adopting at scale in Scotland. And so I won't talk so much about it, but if I can tell you that, you know, if Richard has told us at the start that video technology, video consultation technology it's been around for ages, 10, 15 years, and yet the default way in which the NHS sees people is face-to-face. We do stuff with our hands and not remotely. The COVID-19 crisis has been a real catalyst for change. But as ever, things move slowly in the NHS. I mentioned 17 years before, and so what the NHS did through its command and control decision making was that they created in England a national procurement of 2 platforms, so Attend Anywhere for secondary care and AccuRx in primary care. So video consultation, remote consultation platforms, and that was done in less than 4 weeks, which is an unbelievable achievement. The Academic Health Science Network, so my organisation, supported the initial review of platforms, but NHSX led on the decision in the procurement because that's their expertise and responsibility. In terms of supporting locally our NHS organisations, we helped with options appraisals. But also we offered loan staff to support the rollout and training of these platforms for those that weren't using them already. And now there's almost total adoption of remote consultation across the northwest coast. And I've been on teleconferences and video conferences with primary care and secondary care colleagues from our region who are saying to themselves, why weren't we doing this before? And we're not going back. So hopefully that's some good that will come out of this crisis. I also must also stress that there is potentially a better patient experience here if you can see a doctor at a time and a place more convenient to you through remote consultation. We mustn't forget that. So let me move on to a company called 3D Life Prints. Liz Ashell-Payne will know this company really, really well. They are based in at Alderhay. They have a base at Alderhay. Their expertise is actually in creating 3D printed anatomical models of internal organs for surgeons to practice operations on prior to operating on a patient themselves. And what that does in usual practice is it helps surgeons basically make fewer mistakes and to complete operations more quickly at lower risk and a reduced time, so reduced anaesthesia for the patients that they're operating on, and that's been really successful. You saw a picture of Ian Hennesey before from Alderhay, and he realised that actually if we're going to try and protect frontline workers in the NHS, we need to make sure that we prevent them or give them a way of not touching surfaces unnecessarily. So doors are common touch surfaces. And so between himself and the team at 3D Life Prints, they came up with what they're calling it the infection control. It's the distancer. You can see that the unit cost is reasonable, and actually, if you can see from the diagrams here, it's where you'd put your name badge, your security card, and basically this is a handle with which you can push doors open or activate electronic door locks. And then this hook here is if you need to pull a door closed or open, then you can do that using this hook, and you don't touch the door, and that improves or reduces the risk of infection. And we've been helping that with procurement and distribution channels and awareness across all of our HSNs, so they can inform their NHS organisations that this exists and can be purchased for staff to buy, and is therefore protective equipment for them. So really interesting. To take existing technology and an idea from a clinician to convert that into something that can protect frontline health workers. So a really great story there. The next one I'd like to talk about is really interesting, and at the start of the COVID crisis, there was a real sort of sense that there might not be enough of certain key things, and protective equipment and infection control equipment, is still a very hot topic. And so a company called Northwest Projects, based in Preston, was asked by clinicians to see if there weren't enough of supplies of PPE masks, standard PPE masks, for protection and prevention of infection and cross-contamination, would they be able to manage a solution that could improve the resilience of the supply chain? Would they be able to take developments from existing technology and adapt them for use in health and care? And that's exactly what they did. They took basically scuba masks that you can buy from many sports stores, and they created technology and connectors and valves at the top of them in order to make these suitable for use in hospital and home environments, for CPAP, for infection cross-contamination control for hospital staff, and also for home oxygen users. But there are some key learnings here. So these actually aren't needed now. The social distancing in the UK has meant that the COVID crisis, as bad as it's been, hasn't been as bad as people feared. But these items are ready now if they are needed in the future, and there is a supply issue. This came about through collaboration between trusts, the Innovation Agency, but also universities. But also the mask meets the standard, but there's been limited time to get approval. So how do we get technology like this that's made quickly and hasn't got the time to go through the normal channels of approval, but actually meet the standard? And actually, what this led to was rapid development of indemnities for hospitals or NHS organisations to assume liability and subsume provider liability, meaning that products that meet standard can be made available to frontline staff and patients quickly. And that's also been supported by the government providing easements of equipment meeting specifications, but whose standards have not yet been approved. So really interesting learnings, really interesting story, and there are loads more like this. We've got digital companies that have been supporting the NHS to create contact tracing and symptom signalling apps. Cookson and Clegg is actually a textiles manufacturer, and they're not a digital organisation in the traditional sense, but through their work to create a platform for furloughed seamsters, so people that can sew together garments, they're able to produce now for the NHS in the northwest of England scrubs and gowns and clinical garments at scale, 600,000 a month, and we've been working really hard to help them with the design of their scrubs and gowns, field testing and procurement. And also companies with remote monitoring. Rinicare developed a COVID pod, so for remote monitoring and supporting the diagnostic effort. And again, we've helped them find opportunities within the NHS to support in the COVID crisis. So I'm coming to my final slide, and it's the learning. So it's what have we learned and what are we still learning? So I think, it goes without saying, businesses have been extremely generous with their offers to support the NHS and health and care. The NHS has really surprised itself and proved to itself that it can move quickly. There's been consistent feedback from the front line from clinicians that that actually the removal of red tape and faster decision making means that care is all about the patient, and surprisingly it hasn't always felt that way. So there is satisfaction from clinicians at this time. There have been eureka moments. Why weren't we doing this already? And I think a common theme we've heard today is we must not retreat from the gains that have made our health and care service better. So through things like remote consultation and point of care. And I think we move quickly and we make mistakes, but we can learn from them and refine and adapt very, very quickly. The NHS has proved that to itself. So some other learnings and some potential solutions. The supply chain, as many of us have heard, is just not as robust or resilient as anyone thought, especially for non-hospital care organisations in the UK, like care homes or domiciliary care services. And there are some fixes coming for that. NHS supply chain recognise this, and they're developing a marketplace with eBay. But that's not here yet. And the Innovation Agency team are working with NHS digital teams on a clear language processing platform that could help provide a local marketplace that could support local resilience forums to help care homes, nursing homes, domiciliary care, social care, etc., get hold of supplies urgently through creating a local marketplace. So that really is the end of my presentation. I hope that it's been useful for you, and it'd be interesting to hear comments and questions to the panel. Over to you, Andy.
Thank you very much for that, Mike. Very, very interesting, fantastic innovation using existing products up in Preston. I'm certainly very impressed with that, and there's lots to see and share there. We're just about the end of our session. I think we've got some time for some questions. First question I've got in front of me, this was from Adam again, and I think this is just a quick question. Won't the decision on how care is provided in the future depend on whether the equivalencies are there in clinical outcomes for virtual new care models? So I'm just going to open this up for anyone who's got an input here. Any input from our panelists so far? If you have one, please unmute your microphone and step in.
Hi, Andy. So I think I've probably got something to say here. Do you want to just pose the question again?
Yeah, okay. This was a question from Adam. Won't the decision on how care is provided in the future depend on whether there are equivalencies in clinical outcomes for virtual new care modalities versus traditional? So some cases new models are better, and then others where traditionals are better outcomes. Any thoughts on that?
Yeah. So I think that's a really great question, and I think the new models of care, so remote, virtual, will not work for everybody because people might not be able to engage with the technology, or really might not have access to the technology, so they might be excluded digitally or some other way. So I think there will always be there will always be provision of the traditional methods of care as well as the remote and virtual methods of care. I think we're finding a lot out as we go along, and that some of that work and that research probably needs to be undertaken. I think there are obvious gains that we can make by doing stuff away from hospitals and NHS organisations, GP surgeries. And actually, some of that will be more convenient for the patient, and they'll be willing to engage in it. So a little thought from me on that.
Thanks for that, Mike. Very, very interesting. Liz, there's a question for you from Laurie in terms of have you been able to see a demand not just from the UK but other countries and even further afield? That's a question all the way from Australia.
Yes,
from
we
a
have.
man from Gloucester.
Yeah, so the data that I shared with you wasn't for the UK, that was global data. And we're seeing quite significant interest from countries in Africa. Obviously, if we think about some countries that don't necessarily have infrastructure or services available, actually their need is probably far greater than ours. So they may not have access to teleconsultations, telehealth, telemedicine, etc. And so we're seeing quite a significant increase in different parts of the world. And I think what I would absolutely say is for us and for me personally, when I'm speaking to ministries of health predominantly in other countries, digital is something that is on everybody's mind. You know, this is the way in which a lot of end users, patients, populations want to use digital health. And yes, it's not for everybody, but I think what we're seeing is a massive increase in awareness and accessibility and trust of these products. And that isn't just a UK specific situation. Andy?
Gregor, you're on mute.
Sorry, here I am. So I just wanted to say to Andy, if I can come in, and then nobody responded. Okay. Basically, we said that we will have the discussion in the end. So I invited all of the speakers and panelists who were with us today to turn their cameras on. Some had to go. Andy, unfortunately, cannot use the camera today. But I do have an observation, and I will take Mike Kenny's quotes. You know, so basically, Mike, you said that there is now far less red tape than we saw before. You know, because the information about taking 17 years from innovation to NHS market is like something that you would basically not die for, but from. Because, you know, 17 years is really a long time, you know. So yeah. I thought my Slovenian market is the worst, because there was a guy, you know, that we learned about a year ago who was on his own developing a solution for the diabetic leg, you know, when you can get your leg taken off. And he needed 11 years basically to be allowed to go into the market. So I thought that was the record holder, but apparently, you know, it's the English, you know, who are in front of I don't know, us from Eastern Europe, I would say. So Jon, we are not that bad, I guess.
Well, it's not a stat I'm proud of.
No. Okay.
Okay, thank you for that.
Okay. So do we have some questions? Andy, please, it's your word.
Yeah, is there any other questions from participants?
Not in the system, Okay. So I did send the unmute possibility to everybody who remained, and if somebody would like to even speak up, you can, but otherwise we will lead this to a close. So if there will be no questions, I will basically thank everybody. So Andy, if I may.
Yeah, thanks for your help and your participation in this. I think it's a fantastic opportunity to see from an enormous range input of existing deployment, so of deployment of existing solutions. So thank you to all the participants from Romania and Denmark and the UK. And also from the questions from further afield too. So thanks for everyone who's taken part today.
Thank you too, Andy.
You're welcome. Thank you, Andrew.
Just like to thank everyone. Thank you.
Thank you. Take care.
Thank you. Thanks. Bye-bye. Bye-bye.